how are you?
Alhamdulillah, good.
Alhamdulillah. Can we just introduce yourself one by one? I can see only Hanis. Kwan Zuraidi. Salam. Welcome back.
Salam.
For all of you. Okay, who is the next one? Amira? Or Amina?
My name is Amina, yeah.
You are welcome. Who else? Abdullah Hakim.
Yes, doctor.
Welcome back, Abdullah. Afiq Nasir.
Yes, doctor.
Welcome. Hanis Hamdan. Okay. Hanis.
Yes, doctor. Yes.
Okay, welcome back. Ikwan. Okay, Zuraid. Noor Nabila. Yes, Ikwan.
Yes, yes, doctor.
Okay, do you need to tell us anything? Okay, we have Noor Nabila twice or once? I can find the two. Noor Nabila.
Yes, I used to device.
Oh, mashallah, VIP person. Welcome. And what? Mukhtar?
Husna, doctor.
Okay, and we have one Nabila also. Noor Nabila and one Nabila. Good, good, good. Okay, I hope you got my message. I'm trying to give you the best benefit of online teaching. I practiced it really was the 5th year when we closed on previous March, and we got decision with year 5 that the same scenario which I did, and I see it helped them a lot, even for the final pro. Alhamdulillah, because we took decision for all college to do it as a modified short case, so they know how to get a shared history within 15 to 20 minutes, how to discuss, how to think about differential diagnosis. What about OSCE? Because also we retrieve the non-human OSCE, which is very important. So who will be the first group for the first patients?
Me, Nabila, Wanabiha, Aida Sabrina, and Abdullah Hakim.
Okay, who will be the doctor at this one?
Abdullah Hakim.
Sorry? Whom? Abdullah Hakim. Oh, mashallah. Okay, so today we are going to give the mark for Abdullah only, but all of you I will give you bonus for your support. You can start, Dr. Abdullah Hakim, now. Taking history in front of us, it may be 15 to 20 minutes. I need someone who regulates that time. Okay. And after that, we are going for the OSCE and the differential diagnosis. Okay. Bismillah.
Bismillah. So my name is Abdullah Hakim. So our group today will be discussing about the case of acute gastroenteritis. So here are the table of contents. So we'll go through history taking, physical examination, and then we will go through the differential diagnosis, investigation, discussion, and lastly, we will answer some OSCE questions. So we begin with history taking, the role play. So I'll be the doctor, and Wan Nabiha will be the mother of the patient. So let's start. Good morning. So my name is Abdullah Hakim. I am the doctor in charge. May I confirm the patient's detail?
Yes, you can.
So the patient's name is Muhammad Safwan bin Muhammad Rizal.
Yes.
Age 2 years, 11 months old. Is it true?
Yes.
Okay. So how should I address you, Miss?
You can call me Puan Wan.
Okay, Puan Wan. So may I know your relationship with Safwan?
I am his mother.
Okay, your mother. So for this history taking, I would like to ask you some questions if you don't mind. Is it fine for me to take some notes throughout the conversation?
Yes.
Okay. So firstly, may I know why is Safwan being admitted to the hospital?
He having episode of vomiting and diarrhea for 1 day.
How many times does he had diarrhea?
I think he had about 3 episodes. The first episode happened at 2:30 in the morning. Second one at 6 in the morning, and the third one at 8 a.m.
Do you perhaps notice the color of the stool? Is it watery or not?
I noticed that the stool kind of like watery and brownish in color.
Any blood or mucus?
No.
How about the smell of the stool?
I also noticed that the stool have very foul smell.
Okay. So may I know, does your child wears diapers?
Yes.
Can you describe how each episode of diarrhea affect his diapers?
The first episode it kind of stopped, but it doesn't overflow the diapers, and it becoming lesser and lesser in each episode.
Do you notice any pain associated with the diarrhea?
My son told me that he showed me that he has pain on the umbilical area, so I just put some ointment there, and he continued to sleep after that. So I think maybe the pain was subside after I put the ointment.
So you also mentioned that he had vomiting. So
Yes.
how does he develop the vomiting? Is it before or after the diarrhea?
He after he diarrhea he developed vomiting. He vomit about I think 6 to 7 times a day. And the first episode happened at 2:30 in the morning. But it was just a simple vomiting. Not the projectile one.
Oh, I see. Can you estimate the volume of the vomitus?
I think it's about half liter, about 500 milliliters.
So what's the color of the vomitus?
It was just brown in color. I don't notice any blood. I think because he only drink milk and Milo before he go to sleep. Before.
Yeah, I see. So how about his appetite?
I also noticed that the next day he doesn't want to eat. He lost his appetite and he only drink water. But he continued. He started to vomit after he drink water.
I see. Okay, so do you notice any differences in his activeness?
Yeah, he becoming like so not active, like he like lethargy.
Any changes in urine output?
I also noticed that there are only a little urine on the pampers.
So any other physical changes that you notice on your son?
I noticed that his face was kind of pale and also that his lip was dry.
So are there any other family members that has similar symptoms like him?
Oh yeah, my daughter also has the similar symptoms as a friend. He also had been admitted to pediatric wards 2 days prior.
Okay. Okay. So do you notice any fever on your son?
Oh yes, I noticed fever when on admission.
Are there any history of coughing, sore throat, runny nose, or rashes?
No,
Does your son ever eat outside food?
no,
No. Any recent traveling or jungle or water activities recently?
no,
Do you ever change his diet, like his formula milk?
no,
No. Okay. Um, okay. Have you ever changed to a new packaging of milk or anything?
I started to notice that I think the symptoms started where they started to drink milk from a new packaging.
I see. Okay. So I would like to ask about your housing area. Any dengue cases or fogging done in your area?
No,
Okay, let's proceed with birth history. So during pregnancy, is there any history of gestational diabetes?
no. I was healthy on my pregnancy, but I was diagnosed of anemia on my third trimester.
I see. Okay. How about during delivery? Was it done by normal delivery, spontaneous vaginal delivery, or during using surgery?
Spontaneous vaginal delivery.
So during postnatal, does he develop any illnesses or jaundice?
Yeah, he developed jaundice on 7 and 8th day, but he doesn't require any treatment.
I see. So is this his first hospital admission? Any illnesses or surgery before?
Yes, this is the first one.
Does he take any drugs before?
No,
Any known allergies?
no.
How about his vaccination schedule? Vaccination? Does he take vaccination according to schedule?
Yes, he has complete vaccination.
I see. So is there any allergic reactions after vaccinations?
No, no.
So how many siblings does he have?
He has 3 siblings. He's the third one.
Okay. How old are the other two siblings?
Uh, he has 2 sisters. The first one is 6 years old, and the second one is 4 years old.
I see. So the one that has similar symptoms like him is
He's the
the one?
second child.
Okay, second child. So how old is your husband?
My husband is 36 years old.
Any known allergies or illnesses?
Oh yeah, he has allergic to seafood.
So how old are you?
I am 28 years old.
Any illnesses or allergies?
No, no.
Okay. So any known allergies or illnesses among his siblings?
My eldest daughter have eczema and sinusitis.
Okay. So may I ask, do you and your husband are related to each other like cousin?
No.
Okay. So then we proceed with the summary of the HOPI and several review from the history taking. So summary of the HOPI, Safwan, 2 years, 11 months old Malay boy, presented to ED with complaints of diarrhea and vomiting for 1 day duration. So he had 3 episodes of diarrhea. The stool was watery and brownish in color with no mucus or blood noted. So this diarrhea is classified as Bristol 7 with full smell. Additionally, he vomits about 6 to 7 times on the day of admission, and the volume was about 500 milliliter, brown in color, and no blood detected. Generally, he seems pale, not active, and lethargy. He had poor oral intake and decrease in urine output. Her elder sister also had the same symptoms and was admitted at the pediatric wards of HDAA. and they are not living in dengue-prone area and no history of recent traveling or water activity. So for system review, so the mother had mentioned that Safwan had fever, loss of appetite and lethargy. So for gastrointestinal system, he had episodes of vomiting, diarrhea, and abdominal pain. For genitourinary system, the urine output and frequency were decreased. Next, for birth history, during pregnancy, the mother had anemia in third trimester, while during delivery, it was uneventful. And after delivery, Safwan had jaundice on 7th and 8th day of age, but did not require phototherapy and no admission to hospital. So we will discuss a little bit about the physical examination that had been done towards this patient. So firstly, the general examination. So for examination, only the general examination have positive findings, while others only have negative findings, but we'll go through one by one. So for general examination, there are 2 positive findings, which are conjunctival failure, you can see at the picture at the right side, and also dry lips. So these 2 criteria fit with the description of mild dehydration. For it to progress to moderate dehydration, the patient must present with sunken arms. So for negative findings, there are many. And then for anthropometric measurement, so the weight is between 5 to 10 centile, 10.3 kilogram. The height is 89 cm, and BMI is 13.03. The vital signs, all were normal. The blood pressure is normotensive, heart rate is normal, respiratory rate 48 breaths per minute, normal, and the temperature is afebrile during the clucking of the patient. Next is the cardiovascular examination. The positive findings are 9, and the negative findings are all normal. For example, okay. So for respiratory examination, there are no positive findings, and the negative findings, which indicates normal findings for this patient. There are many. You can read it later. For abdominal examination, also the same. And lastly, the neurological examination. Also no positive findings, all were normal. So we proceed with the diagnosis. Thank you.
Okay. Assalamualaikum. Can you hear me?
Yes.
Yes.
Okay, thank you. So now let's move on to the diagnosis. Next slide, please. So our provisional diagnosis is acute gastroenteritis. So acute gastroenteritis is the inflammation of stomach and also intestine. So the patient is presented with diarrhea and vomiting a day prior to admission. And there is also abdominal pain that supports this diagnosis, as well as loss of appetite. Patient also has signs of dehydration, such as pale and dry lips, lethargy, decreased urine output, and decreased frequency of urination. And then there's also history of new packaging of milk, as well as the patient sibling having the same symptoms as the patient. So these two are also the supportive point for acute gastroenteritis, because acute gastroenteritis can be acquired through person-to-person spread, or also through ingestion of contaminated food or water. Okay, next. For our differential diagnosis, first is parenteral diarrhea. Parenteral diarrhea is diarrhea that is being caused by infections that is outside of the gastrointestinal system, such as urinary tract infection, upper respiratory tract infection, or otitis media. So points that support this diagnosis is the patient is having diarrhea, vomiting, fever, and also signs of dehydration. However, during physical examination and history taking, there is no urinary tract infection symptoms. There are also no upper respiratory tract infection symptoms, and there are also no ear discharge that can show that the patient is having otitis media. Next. For our next differential diagnosis. Next slide, please. Thank you. Okay, for tadi back. Okay, thank you. So for the next one is acute appendicitis. So acute appendicitis is one of the most common emergency case, surgical case in children. So for the points that support this diagnosis is diarrhea, vomiting, fever, and also decrease in appetite. We know that the patient is having abdominal pain over the umbilical region. However, from what I read in Medscape, it says that the classic history of acute appendicitis in children is abdominal pain over the periumbilical region, and then later it will migrate to the left to the right lower quadrant. Only when the pain has migrated to the right lower quadrant, only then the pain will be severe and continuous, or else the pain is not that severe. Okay, and however, the points against acute appendicitis is that upon palpation there is no abdominal tenderness. Okay, moving on. Next is dengue fever. So the patient is having fever, diarrhea, vomiting, signs of dehydration, and also abdominal pain, which can be a warning sign of dengue fever, as well as persistent vomiting, because the patient is having 6 to 7 episodes of vomiting in a day. However, there are no chills or rigors that come together with the fever. There are also no skin rashes noted on the patient. There are also no bleeding tendency, no joint pain, and the patient is also not from a dengue-prone area. Okay, next, moving on, is cow's milk protein allergy. So this is a known potentially serious complication of acute gastroenteritis. So the points that support for this are diarrhea, vomiting, and also abdominal pain. However, we cannot see any acute rhinitis or conjunctivitis in this patient. There are also no rashes, urticaria or eczema, no angioedema, and also there is no history of changing formula milk. Okay. And last is lactose intolerance. So lactose intolerance is a digestive disorder caused by the inability to digest lactose. So the points that help to support this are diarrhea and vomiting. However, there is no abdominal distension in the patient. There is no increase in flatulence and also no burping. That's it.
Next one, we move on to the investigation. Next slide. So the first investigation that we can done is blood investigation. So the first one is a full blood count. So we do the full blood count to look for any sign of infection by looking at the lymphocyte and also the neutrophil. So as you can see, the results shows that they are normal parameter of all, but they are increasing in the neutrophil. So the neutrophilia can suggest bacterial infection. Okay, but the eosinophila is normal, so it may not suggest any dengue fever. So the next one is the next investigation that we can done is a renal profile. So the renal profile done is to detect any electrolyte imbalance, so that we can assess any the kidney function and hydration status as the patient having an episode of diarrhea and vomiting. So based on the results, you can see that there are no electrolyte imbalance observed, but they are high in the urea is high, may suggest the dehydration. However, but there are no evidence of renal impairments. And then next one. We also can do a calcium, magnesium, and phosphate. So we do this test to look for any sign of gastrointestinal malabsorption. As the all findings are normal. Next one. Other investigation that we can done is venous blood gases. So we do venous blood gases to observe metabolic acidosis in patient due to the metabolites lost in the diarrhea. But in this patient, we not done. But this test is not done in this patient. The next one is the urine flow examination and microscopic examination, UFEME. We do this to look to exclude any parenteral diarrhea that may arise from URTI, but this test is not done in this case. The next one is stool culture and sensitivity. We also do this test to look for any causative agent. The most common causes of acute gastroenteritis are rotavirus, but these tests are not done in this case. The next one is a stool full examination and microscopic examination, which is a stool FEME. We also want to look at any presence of cyst or trophozoite in the stool if there are parasitic infection that can cause the diarrhea, but this test also not done in this case. Based on the investigation, the final diagnosis is acute gastroenteritis with mild dehydration.
Hello, can you hear me?
Yes.
Assalamualaikum warahmatullahi wabarakatuh. So we move on to the discussion of acute gastroenteritis. So acute gastroenteritis is referring to a diarrhea which is abnormally frequent and liquidity of fecal discharges, and it often comes with vomiting. So acute gastroenteritis contributes to a leading cause of childhood morbidity and mortality, and it is one of the important cause of malnutrition. So most of the diarrhea deaths are caused by dehydration and electrolyte loss. So diarrhea is caused by different infectious or inflammatory processes in the intestine that can directly affect enterocyte secretory and the absorptive function. Next. So the causes of diarrhea can be further divided into three, which is either viral causes, bacteria causes, or parasites. Next. Okay, so the most common causes of gastroenteritis is a rotavirus infection, which accounts of up to 60% of cases in children under 2 years of age, particularly in developed countries. So other viruses such as adenovirus, norovirus, coronavirus, and astrovirus may also cause outbreaks. Bacterial causes for gastroenteritis is less common in developed countries, but it can be recognized by the presence of the blood in stools. The Campylobacter jejuni is the most common causes and is associated with severe abdominal pain. Shigella and Salmonella will produce a dysentery type of infection. Usually Shigella infection, patient will present with high fever. Cholera and E. coli infection are associated with profuse and rapidly dehydrating diarrhea. As for parasites, Giardia lamblia and Cryptosporidium parvum can cause diarrhea. As for pathophysiology of acute gastroenteritis, it is further divided into invasive diarrhea and secretory diarrhea. As for invasive diarrhea, there is an inflammation and reduced mucosal surface area, colonic reabsorption, and increased mortality. While in secretory diarrhea, there is a decreased absorption, increased secretion, and electrolyte transport, meaning that the secretion exceeds absorption. The secretion function exceeds the absorption that leads to diarrhea. So in invasive diarrhea, there is dysentery, and the stool examination will reveal presence of blood and increased white blood cells. But as for secretory diarrhea usually persists during fasting, and bile salt malabsorption may increase intestinal water secretion. And there is no stool leukocytes in secretory diarrhea. The stool examination will reveal the watery stool, and the stool will have a normal osmolality. Next. Signs and symptoms of patient with acute gastroenteritis is vomiting, diarrhea, edema, and eosinophilia. Patient may also present with having a fever, lethargy, and abdominal pain. So the differences between viral diarrhea and bacterial diarrhea. As for viral diarrhea, the diarrhea will produce a watery stool with no blood or mucus. Patient will vomit, and in infant and young children, the dehydration might be severe in viral diarrhea. But in bacterial diarrhea, it may result in a dysentery type of infection, and patient can have a high fever, tenesmus, and pain with pus and blood in the stool. Next. The management of a patient with acute gastroenteritis is important to assess and monitoring level of hydration status, because dehydration is one of the prominent features of diarrhea. So we need to know the degree of dehydration, whether either it is mild, moderate, or severe, in order to treat patient. So how to assess the degree of dehydration? As for mild dehydration, patient is well, alert, and there is no sunken eyes. Patient also will drink normally, and after the skin of the abdomen is being pinched, the skin can goes back normally. As for moderate dehydration, if patient have more than 2 of this sign, which is restless, have sunken eyes, drinks eagerly, and the skin goes back slowly after being pinched. And as for severe dehydration, when patient have more or equal to two or more of these signs, which is lethargy, presence of sunken eyes, not able to drink or drink very poorly, and the skin goes back very slowly, which is more than 2 seconds after being pinched. So as for mild dehydration, we treat as plan A, and as for moderate dehydration, we treat as plan B, and severe dehydration, we treat as plan C.
But sorry
Yes.
to stop you here, because it is not the only parameter that we define. What is the meaning of less than 5%?
Sorry,
Or
doctor?
between 5 and 10? What is the meaning of classify less than 5% dehydration?
Meaning that
Urinary.
okay. Afiq?
Is it the urinary output, doctor?
No, it is loss of weight. We are
Yes.
classifying the diarrhea to mild, moderate, severe according to the weight loss.
The
Okay,
formula
so up
to
5,
calculate
it is mild. Yeah, so it is very
is
important. Yes. So this is number 1. Number
according
2,
to the weight.
I was going to discuss Abdullah for that, but signs of dehydration, yeah, this is the main points which you speak about, but we have a lot to comment, especially the vital signs. Remember in your medical practice that vital signs are vital. If the patient got severe dehydration, the most common complication is shock.
Shock. Sorry.
What will happen? So you must comment about the capillary refill time. You must comment about the pulse, is it high or not. You must comment about the blood pressure, even respiration, because most of them, if they became bad, they are going for metabolic acidosis, and respiratory effort also will increase. Okay, so it is very important to, yeah, it is a good as a starting, but I just need to just add it as extra line down. Okay, good. You can continue, Aida.
Nabila, doctor.
Aida or Nabila? Okay.
Nabila.
Nabila. Nur Nabila. Okay.
Yes. Okay. Next, Husna. Okay. As for our patient, he looks alert and conscious. His eyes were mildly sunken, and the lips were dry and appeared chapped. The capillary refill was found to be less than 2 seconds with good pulse volume. The skin goes back immediately after being pinched. which shows there is a good skin tegor. Patient's renal profile shows a slightly high level urea. So this suggests the presence of dehydration. So as the patient progresses, we found out that this patient is having a moderate dehydration with a 5% fluid loss. Thus, plan B was carried out for this patient. So he was then given oral rehydration solution to rehydrate and intravenous drip HSD5, sodium chloride 0.445%, dextrose 5%, 41 cc per hour for his fluid maintenance, as well as intravenous drip normal saline 42 cc per hour for 12 hours for his 5% correction of fluid loss. So the main complication for acute gastroenteritis is dehydration and hypovolemic shock. The seizure may also develop with high fever, particularly with Shigella infection. Shigella and Salmonella infection may lead to a development of intestinal abscesses, which can lead to intestinal perforation. Esophageal tear and aspiration pneumonia may also occur from the severe vomiting. The destruction of fluid and electrolyte homeostasis in diarrhea can result in death as it causes dehydration, electrolyte imbalance, vascular instability, as well as shock. Next. So the preventive measures are the key factors for AGE, for acute gastroenteritis, because it can reduce the mortality rate for AGE. So we need to always provide a clean and uncontaminated water, and a good hygiene should also be observed in premises, whether in preparing or serving food. Next is to practice proper hand washing because it can reduce the incidence greatly. And last but not least is rotavirus vaccination. That's all for the discussion of acute gastroenteritis.
Okay, Assalamualaikum. I, Husna, will be presenting the OSCE. So this will be a discussion. Either most of us remember the topic prior to the reading or during the previous discussion.
Can you increase the volume?
Right. Okay. As we all know, during history taking, we ask the patient about the consistency and the shape of the stool. So we can do this using Bristol stool chart. As it is one of the diagnostic to evaluate the feces based on shape and consistency. So I would like to ask the floor from type 1 until type 7, how can we differentiate both of them? For type 1, anyone?
For type 1, it is a separate heart lumps, which happens in severe constipation.
For type 2?
It was lumpy and like a sausage. It also categorized as mild constipation.
As you can see, thank you Afiq and Wan. Type 1 and type 2, mostly if the patient have constipation, that may show the patient have constipation, severe or mild for type 2. Then for type 3, anyone?
If I'm not mistaken, type 3 and type 4 is normal.
True. For type 3 and type 4, the feces indicates normal. For type 3, it shows association with crack in the surface, while type 4 is smooth, soft sausage. While for type 5, anyone?
It looks like a soft block, but then it has clear edges. This is like when there is lacking fiber.
Thank you, Aida. So, and type C and type 7, I think already most of us can already conclude that type 6 is for mild mild diarrhea, and type 7 is for severe diarrhea. Next, we go to this picture. As we all know, there's some signs for dehydration that we will refresh back later on. So what's this picture indicate?
It indicates a sunken fontanelle. It is one of the major causes. One of the major causes of sunken fontanelle is dehydration.
Okay, thank you, Nabila. This indicates sunken fontanelle. Next, anyone? Can anyone comment about this picture?
It is reduced skin turgor.
What kind of test we do? It's a pinch test.
Pinch test.
Okay, so this, as we pinch the area of this baby, we may see that it is retract back slowly. So it may indicate reduced skin turgor. It is one of the signs of dehydration. And next we go to the hydration status. From mild to moderate to severe. First, for general appearance, anyone?
Alert, well, normal.
Okay. For the mild, the patient may appear well, while for starting for moderate, the patient may show some lethargy, and if it becomes severe, the patient may become drowsy, and even the worst part is it may become coma. Okay, then we go to the anterior photonia. As we can say, Nabila said before, it is a sign of dehydration. Anterior photonia may appear sunken, start at the moderate, and then to the severe one. For the eyes, anyone?
It can be normal or it will be sunken if it's moderate or severe dehydration.
Yeah, true. Thank you, Amina. For the eye, for the tears, anyone?
It can be normal or it can be reduced, and for severe dehydration, there would be no tears.
Okay, thank you. So for patient in severe dehydration, we can see the patient have tearless at the eyes. So take note is as one of the sign of severe dehydration. And then for thirst,
Husna,
yeah.
I would like to ask, so like we ask the patient to cry, is it?
He's crying automatic.
Maybe
Crying
it's
automatic.
automatic, right?
So what if the patient is not crying?
If he is not crying, you must be very, very afraid. He has conscious level is disturbed.
Sorry, the question is really clear now.
From what I know, baby will cry if they see a stranger, right, doctor?
Sorry?
A baby will sometimes cry when we see a stranger. So it's like high chances that they will cry to see us when see us.
Your voice is not so clear. Can you increase the volume?
I repeat, maybe because we as a stranger meeting the baby for the first time, they will cry eventually. Right?
Yeah, this is astringent anxiety. It is a scientific phenomenon known as astringent anxiety. It will occur usually from the age of around 9 months until 2 years, like that. Okay? Yeah, you are correct.
Thank you, doctor. And then we proceed to thirst. Anyone? Is one of the sign we will see we want to search to assess hydration status. Okay, I proceed. If the patient is mild dehydration, there will no be presence of thirst. While if for moderate, the patient may become thirsty, and for the severe dehydration, it become refuse to feed. For mucous membrane, like we can see in the history taking, as the patient is have dry dips, it may because and from mild to moderate to severe, it moist, dry, and into very dry. For pus, as doctor mentioned, we need to remember the vital signs. Anyone?
For pulse, if there is no dehydration, it will be normal pulse. But in moderate dehydration, the pulse will be a bit rapid and still there is a good volume. However, when there is a severe dehydration, the pulse will be rapid and it can be weak.
Uh, thank, thank you, Afiq. And for the respiration, it's mostly at first it mild dehydration. It is normal. However, as it progress to moderate and severe, become rapid bleeding, tachypnea. The patient may become tachypnea, and it is become more severe. It become the finding of Kussmaul bleeding. For the BP, anyone? Blood pressure?
What is the Kussmaul breathing?
It's like
Deep and rapid breathing.
Or rapid breathing?
Deep breathing.
Yes.
deep and rapid breathing,
Yes.
right?
Yeah. If you saw it like the patient of diabetic ketoacidosis, it is the same. The DKA got this type of breathing because also dehydration and like that. It means usually if it present, it means metabolic acidosis. Okay, continue. Good presentation.
Okay, for BP, first in my dehydration, the BP may be normal. However, if become moderate dehydration, it become slightly hypotensive, and if it become more severe, it's become the reading may become unrecordable. So we proceed to CRT, capillary refill time. Anyone?
For
Abdullah?
so for capillary refill time, in mild dehydration, the capillary refill time will be less than 2 seconds, normal. For moderate dehydration, the capillary refill time may be normal or prolonged, around 2 seconds. And for severe dehydration, it will be more than 2 seconds.
Okay, thank you, Abdullah. And then for skin turgidity, as like our previous colleague has already said, and as I show in previous picture also, we do pinch test, and then if it's retract back slowly, it shows reduced skin turgor. So in uh, my dehydration, it may become normal. The skin turgidity is normal, while for moderate, it becomes slightly reduced, and severe, we can see it clearly is reduced skin turgor. For urine output, as we can see in this patient, there's a reduced urine output. They may show reduced, maybe indicate of signs of moderate dehydration or even normal. Okay, and for urine output, if the urine output is still normal, it may shows mild dehydration, while for diminished and concentrated urine, it may become a sign of moderate, more points toward moderate dehydration, and for marked oliguria is for severe dehydration. Okay, I repeat back the sign of dehydration. First, the sunken fontanelle, reduced level of consciousness, dry mucous membrane, reduced skin turgor, sunken eye and tearlessness, reduced capillary fill time, tachycardia, hypotension, and oliguria. And there's many more as I state on this picture. Next, we go to common etiology of gastroenteritis. As we can hear from our previous presenter about the common etiology of acute gastroenteritis. Anyone can say what are the causative agent for virus gastroenteritis?
Norovirus and rotavirus.
Yeah, true. And mostly common in pediatric patient is rotavirus, and the next one is norovirus. Okay, and for any causative agent for the bacterial gastroenteritis, anyone?
Salmonella.
E. coli.
Campylobacter.
Okay. Thank you, everyone. So, the one of the commonest is E. coli, followed by Salmonella and Campylobacter. For parasitic, anyone?
Giardia lamblia.
Yeah, true, is Giardia. Okay, and then we proceed to the difference between the etiologies. As I think everyone still remember what Nabila presented before, between viral and bacterial, anyone?
Viral diarrhea is presents with watery diarrhea, and the stools are rarely contain mucus or blood.
Okay. For bacteria?
Usually, it has besides yes, bloody diarrhea, and also comes with fever.
Thank you, Afiq and Iqwan. So, the viral is mostly watery diarrhea, and for bacteria, it can be present with two. If it's invasive kind, like Shigella and Salmonella, it may become dysentery, present with dysentery. While for E. coli infection, first and foremost, it will become watery diarrhea, secondary diarrhea, and then it may be followed by dysentery. So one of the commonest dysentery that may present to our patient is Salmonella in nature. Okay, and then we proceed to parasitic. It's mostly non-bloody diarrhea. And next, the final question I will ask is, there's a
Come
picture.
back to the parasitic. Come back to the parasitic one.
This one, Doctor? No.
The diagnosis of dysentery, which is caused by parasite, is contain blood. The definition of dysentery is blood, mucus, and tenesmus. Okay.
Oh.
Like amoeba, Giardia lamblia, like this, all this will be presented by blood, mucus, and dysentery.
Okay.
We need to correct this one. Okay.
Okay. Okay. Thank you, Doctor. Okay, we proceed to the last question. This picture shows a preparation of medication. What is the name of the medication? Anyone?
Oral rehydration salt.
True, ORS, or oral rehydration salt. What are the ingredients in it? Just a simple one, if possible.
Sugar.
Natrium?
Yeah, natrium. One of them is natrium. Sodium, sodium solution. And next, another one is either is a complex carbohydrate or 2% glucose. And then, can anyone explain the way to prepare and administer and when to give ORS to the patient? I think I will give the answer directly. And as is, how to prepare ORS is by simply empty the sachet into a cold boiled water, and then we mix it through using a spoon, and then eventually we will give it to the patient. If it's infant, we use spoon, and if it's young children, we use cup. As I listed here, for children under 2 years old, we give 1 teaspoon every 1 to 2 minutes until it's until the solution is empty. And for older children above 2 years old and adult, we give frequent sip directly. I think that's all from me. Thank you.
So we are going to come back now to Abdullah after we give him all the knowledge. Where are you?
Yes, doctor.
Are you ready? So, okay, thank you for all of you. It is a good starting for me. I hope, inshallah, if you are still building yourself, you will be a good and competent doctor, because our job, inshallah, in the next 1,000 days, it looks like that. You still have year 3, year 5, year 4, year 5, is to build yourself. And every day will give you something new in your clinical sense. Of course, knowledge must be, but we need also to put your clinical senses. You are able to be competent, not inside Malaysia by hoping you can be competent, inshallah, internationally. Okay.
Inshallah.
So your diagnosis is
Acute gastroenteritis with moderate dehydration, because during the progression, the patient appears to have sunken eyes and dry lips.
okay. So why you said acute?
Because the duration of the diarrhea itself is only 1 day.
When you are going to say chronic?
When it is more than 2 to 4 weeks, if I'm not mistaken.
Yeah. So usually after 2 weeks, you are going to say it is chronic. Some said it is persistent after first or second week, and then after that they will say chronic. But usually after 2 weeks, you are able to say it is chronic diarrhea. So just put it aside and remember that there is an important causes of chronic diarrhea. Okay. Of course, the most famous for that is infection for the gut known as chronic inflammatory or malabsorption or like that. Okay, so most of these are a bit critical and important to be diagnosed. Okay, but for acute diarrhea, can you tell me the rationale why all the textbook used to say that the acute gastroenteritis is one of the most common disease of a childhood morbidity and mortality? Did you agree with there, or you are making it a bit over?
I think maybe because the complication of the acute gastroenteritis leads to the morbidity and mortality, but The most common one, I'm not so sure about that. Maybe anyone knows?
Maybe because of the severe dehydration caused by the a lot of vomiting. So because of the severe dehydration, it could lead to shock, hypovolemic shock.
Good. So that's why we must document, if we said acute gastroenteritis, we must document that the degree of dehydration. So shock not only cause this complication, any other complication of shock or gastroenteritis together. Usually, what we lose is if someone got vomiting and diarrhea.
The electrolytes and the fluid.
Yes, he's losing fluid, water, and electrolytes. Many of the family will compensate it by plain water. So usually we are going to get electrolyte disturbance. You must know that some electrolyte disturbance can be life-threatening. What is the most important electrolyte, Abdullah?
Mistaken sodium.
Yes. That's why we are classifying the diarrhea into 3 types, which is hyper, osmolar, iso or hypotonic, isotonic, and hypertonic. All this dependent on the sodium level. So don't forget that the sodium will help us, because inshallah, if you became more practicing, you will see some cases of the most common is hypotonic. I mean that the sodium is low. That's why you are giving the sodium chloride. But some cases you will find it isotonic. You are not in need of give a lot of sodium. But if it is hypertonic, you must give a slower amount of sodium. You cannot cut it completely, because sodium, if you decrease it rapidly, it can cause lysis of the brain cells. So it is very important for sodium and for potassium also. What potassium can cause? Can cause paralytic ileus. Hypokalemia can cause paralytic ileus. So it is very important. So number 1, shock. Number 2, electrolyte disturbance. Number 3, which is very important, what is the organ?
Kidney injury. Renal failure.
Thank you. It's good. So acute kidney injury. Why? The kidney is, its function is to excrete every minute a lot of water, absorb again some of it, and it can do urine with its excretion. That's why you must ask the mother. Don't forget, Abdullah, again. What about the wee? What about the kitchen? Okay, is it passing as normal or not? It may be the mother tell you, oh, really today I didn't change any diaper contain urine, only stool. It is very dangerous. Okay, so that's why we are treating the dehydration, because acute kidney injury. And even if you left the patient with chronic acidosis and all this, the patient can go for something known as DIC, disseminated intravascular coagulation. Okay, so it is very important. So I think now we can add some more points, Abdullah. So our diagnosis now is acute. Is it viral or bacterial?
I think it's viral because of the characteristic of the diarrhea. It's not bloody diarrhea, and also it is watery. So most likely it is viral acute gastroenteritis with moderate dehydration.
How old is your patient?
2 years, 11 months old.
Yeah, usually rotavirus will occur in the first 2 years.
Rota.
Will occur early. Okay, so the patient has fever. Yes.
Yes.
So you must take care, is it bacterial or not, especially if it is long time fever, especially if you got some other changes. Okay, so maybe acute infective diarrhea, either bacterial or viral, because sometimes it is non-infective. It may be a part of systemic disease as the presentation. That's why the next question for Afika, for Afik Nasir. Afik,
Yes, doctor.
what is the important organ beside signs of dehydration, which your colleague already presented? And this is the top important. Your responsibility for assessing the degree of dehydration are very, very, very vital. What other organs do you need to examine? Your colleague said yes. Huh? Okay, let us make it more simple. Your colleague said it can be a part of systemic disease known as parenteral diarrhea. A most common cause is dengue. Dengue, with the dengue, most of the warning signs are related to GIT, abdominal pain, vomiting, diarrhea. Okay, so I must examine generally, especially the skin, for dengue rash or bleeding tendency or like that. Also, it can be UTI. UTI in small kids will be presented by vomiting and diarrhea. So you must rule out any issue with the kidney. Otitis media will be presented by vomiting. So you must take care in every patient to make sure that there is nothing in the ear, there is nothing in the kidney, there is nothing in the skin, okay? And don't forget, of course, the degree of dehydrations. Okay, I think your colleague need to add one more slide. What is the composition of the ORS? Especially the modified one, because it is very important. Okay, which is life-saving, especially in remote area like that, in some area who have severe infection or malnutrition or war or like that. Even we are telling them how to do manually the ORS by bringing 1 liter of water and adding big scoop of sugar and half a scoop of salt like that. It is very important, okay? I think that's enough for you for AGE. Now we understand why AGE is one of the important disease of infant and childhood, which sometimes can cause a lot of problem, a lot of morbidity, even a lot of mortality. And we picked an important lesson. Acute gastroenteritis is related to dehydration. They are twin. I used to call it D and D, diarrhea and dehydration. So it is not only 1D, it is 2D. And you must rule out its cause and its severity and the general condition of the patient. If it is chronic, I must take care because chronic diarrhea is a complete different. It may be also a serious disease, which you must diagnose and treat early. Otherwise, the patient, if got more than few days diarrhea, he will go for malnutrition and he became weak and you found him propagated to both pneumonia and the other infection because he started to be not so competent, okay? So please put all these points in your history taking again. For how long is the diarrhea? He has any allergy to food? Okay. What about his eyes? He is crying or not? And if he's crying, he has tear or not? Okay, his eye is sunken or not? What about his nose? What about his? So all these are very important points. Now we can go for the second patient unless you have any questions.
I have a question.
Yes.
What's the difference between watery diarrhea and secretory diarrhea? Are they the same?
No, the reverse is if you see the thing against the secretory is the osmolar diarrhea. It means secretory diarrhea. It means the gut are very, very sick. So she is passing the secretion and the diarrhea, even if the patient doesn't eat. And I think it is worthy to add this one also to the slides or to the differential diagnosis. Okay. If most of the patient, if you let them NPM and start IV fluids, they will stop diarrhea, which is osmolar one. But if it is secretory, like the case of diarrhea, secretory diarrhea means very dangerous. If you come to the pathophysiology and what happened with the mucous membrane and secretion, you will find it very, very dangerous. Usually if in cholera, some area in the world, the unfair world is keen to keep some are not so enough in their nutritional status and the economy. Okay, cholera can occur, especially in our area, and the other area it can come as epidemic in many areas. The color of the stool. Do anyone knows the color of diarrhea in cholera?
Watery diarrhea.
Watery, but the color.
Is it yellow or
Remember, it is like
Rice.
rice,
Uh,
ice water diarrhea.
rice water. Yes.
If you found it very pale and very white, take care because your IV fluid will save the life. This time we are going to put two big cannulas and make the IV fluid running more rapid than the diarrhea. Otherwise, the patient may get shock and die. Okay. Any other questions? Okay. So we can go for the second case.
Can you see the slides?
yes, yes.
Okay. Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So my name is Afiq, and so today my group consists of me, Afiq, Ikhwan, Hanis, and Aminah. So today we'll be discussing on the case scenario regarding a case of pneumonia. So this case involves a patient named Nur Ifat Hafia, a 1-year-old, 7 months old a Malay girl that has been presented to the emergency department of Hospital Pekan for high-grade fever for 5 days. So firstly, let us begin with the history taking role play. So I will be the doctor, Afiq, and Ikhwan will be the patient's mother.
That's me.
So yeah, so let's begin the role play. Okay. Assalamualaikum, Puan. My name is
Waalaikumsalam warahmatullahi.
My name is Afiq. I'm a third year medical student. So how should I call you?
Yes, you can just call me Puan. But actually, by the way, I'm still young. Okay.
Okay. Okay, I'll just call you Puan. So can I have an interview with you regarding your child?
Yes, yes, sure, sure.
Okay, thank you. So actually, what is your relation with the uh the the patient here?
Yeah, he's my daughter. She's my daughter.
Okay. So can I have a bit of the details for the patient?
Oh,
What?
okay, it's okay.
So what's her name?
Oh, her name is Nur Ifat Hafia. Nur Ifat Hafia. Yes.
How old? Okay. I shall call her Ifat. Can it? Can?
Okay, it's okay.
Okay. How old is she?
Oh, today 1 year 7 months.
Okay. So what seems to be the problem here? So why is Ifat admitted to the hospital?
Oh, actually, my daughter was well at first, but about 5 days ago, before admission to the hospital, she got high-grade fever. So I'm worried about that.
Oh, I see. So before we start the interview, can I jot down some things, a few bit of information regarding Ifat?
Oh, okay. Okay.
All right. Okay, so let's begin. So Ifat has a fever for 5 days now.
Yes.
So
Sorry,
can you can you tell me more about the fever?
the second case.
Oh, I guess it is a high-grade fever because I do have thermometer at home to record the temperature, and it shows about 39 degrees Celsius to 40 degrees Celsius. And I have checked it daily, and one more thing, it is the
Assalamu alaikum.
temperature peak at night.
Ikwan,
Yes?
Dr. Alawi will be now observing you for the second case. Okay? Go ahead. He is with us now.
Okay.
Okay, doctor.
Okay.
Okay, so continue. So Ifat has a temperature of 39 degrees, 40 degrees,
Yes.
and the fever, does it peak at night, right?
Yes, yes.
Okay, oh, I see. So, what did you do to relieve the fever?
Oh, actually, 2 days prior to the admission, I have sent her to the emergency department in the hospital Pekan, and then the doctor recorded her body temperature. And after that, the doctor give the medication. If I'm not mistaken, he give the antibiotic and paracetamol. So I give to my daughter, but she did not finish the antibiotic treatment. And then
Oh,
actually the fever was relieved for 1 day, but then it come again. So yeah.
oh, I see. Um, Anything you want to tell about more regarding the fever? So that because of the fever, that's Ifat looks tired and lost her
Oh
appetite.
yeah. My daughter seems so tired, and due to that, she doesn't want to eat or drink anything, and much less usual lah. And also in the midnight, she keep woke up and also always get sleep disturbance and also being irritable. Yeah.
Okay, oh, I see. Okay, other than fever, is there anything else?
Oh, beside fever, she also have cough, and if I'm not mistaken, for this prior to the admission, yeah, she also have cough.
Okay, how is the cough? What is the characteristic of the cough? Is it productive or dry cough?
I'm not so sure, doctor, but it's like chesty and productive. Yeah,
Okay, so there is sputum from the cough, right?
yeah.
Can you tell me more about the color of the cough?
From what I see, it is whitish. Yeah, and one more thing, it is the cough worsen at night.
Oh, I see. So because Ifat has cough, does it come with chest pain and shortness of breath?
Oh, no at all, no at all.
Oh, is there anything that worsen the cough?
No, but just it wasn't at night. Yeah.
Oh, I see. So because Ifat has fever and cough, so does that mean that Ifat has met any sick person before admission?
Oh no, we did not allow. We did not allow to visit anyone sick. Recently, no.
Oh, I see. So does Ifat has eczema?
Yes, eczema. Oh no, but sometimes she got sneeze in the morning.
Yes, eczema. Okay. Oh, I see. Is there any other problems beside fever and cough? One.
Yes, actually yes. She has also loose stool sometimes.
Oh, I see. So when did the loose stool start?
Oh, about 4 days ago before admission. And I noticed that it is continuously throughout the day. And every
Oh,
time I check the diapers.
oh, so throughout the 4 days,
Yeah.
okay. So there's loose stool. How was the loose stool? Is it watery or
Oh,
yeah?
the
Is it
stool.
yellowish?
The
Yes.
stool is watery and yellowish in nature. And the amount of stool, I think it is depends on the amount of oral intake that I give to her.
So
Yeah,
because oh
the
yes,
amount of stool.
are there any mucus or blood present in the stool?
Oh no, not at all.
So because Ifat has loose stool, is there previously does Ifat took any laxatives or did she eat outside food or and also did she has food allergies?
Oh no. And I noticed there is redness at his perianal area.
Oh, I see. Redness. Okay, so Ifat has fever, cough, and loose stool. So what
Yeah.
are your other concerns regarding Ifat? So what
Mm,
does other symptoms?
mm, Actually, she has also has vomiting, especially after meal, lunch or dinner. Yeah.
Okay. So this vomiting start 4 days ago. Also,
Yes.
when did the fever? Okay. Oh, I see. So it
And
happens.
also from what I
It
see,
happens 4 days
the
ago.
yeah.
So it happens 4 days ago, and uh it happens after eating. So
Yeah.
it is associated with nausea?
Uh, no, but every time after meal lah.
Okay. Oh, I see. Okay, so the problem here with regarding Ifat, I repeat again, is that she has a fever for 4 days, cough, productive cough,
Yeah.
and also loose stool for 4
Yeah.
days.
Yeah.
Okay, so next I would like to ask regarding um, Ifat's recent admission. Did Ifat has been admitted to the hospital before this?
Yes, actually she has at the hospital Pekan last year. During the age 7 months old, I think. At that
Oh,
time, 3 days ward in the hospital Pekan.
oh, I see. So can you tell me why Ifat has been admitted to the hospital? What's the
Oh,
reason?
due to the rapid breathing and also wheezing. Just just that.
So what did the doctors give to treat the rapid breathing and wheezing?
Oh, the doctor give the nebulizer treatment at the time. And after the discharge, there was no drug. So no drug given after.
Okay, no drug given. So, does
Yeah.
Ifat receive any surgery before this?
No, not at all.
Okay. I would like to ask regarding Ifat's immunization.
Yeah.
Does Ifat receive any vaccination before this?
Yes.
Is it according to schedule?
Yeah.
Is it also, is it complete?
Yes. As the doctor advised. Yes.
Okay, oh, I see. So, is Ifat on medication?
You mean now or what?
Yes, right now.
Oh, actually no, but I frequently visit about once a month in the klinik kesihatan Peramu nearby my town for the nebulizer treatment.
Oh, I see. Okay. Now I'd like to ask about Ifat's birth history. So,
Yeah, okay.
at what age are you pregnant with Ifat?
27 years old last year.
Is there any problems during your pregnancy?
If I'm not mistaken, I've got increased blood pressure just before delivery.
Oh, okay. So at what week is Ifat born?
37 weeks, right? 37 weeks full time.
Okay, 37 week, which means full term birth. So
Yes.
how was Ifat born? The method of delivery?
Through normal, spontaneous vagina.
So what is the weight at birth?
2.67. 2.67. Okay.
Okay.
Yeah.
So next I would like to ask Ifat's feeding. So
Yeah. Okay.
is she still breastfeeding?
I give her up to 2 months breastfeeding, and after that I give formula milk for 6 hours, about 8 times per day. Yeah.
Have you started
Yes.
giving Ifat food, wet food?
Oh, at the age of 6 months, I start give some food about 2-3 times per day.
So you've given you okay. Now I'd like to ask for Ifat's growth development. Can
Yeah.
Ifat
Okay.
walk now?
Yes, she was very active and able to walk herself.
Oh, I see. So can Ifat use the spoon well or scribble using pen?
Yes. Yes, you can.
Can Ifat talk?
No, but she able to point to body part and use 2-3 word sentence sometimes when I ask her to eat.
Oh, used to 2 to 3 words. Okay, I see.
Yes.
So so is she afraid of people? Can she make friends?
No. She was not afraid to people. In fact, she able to make friends during the walks.
I see. Now like to ask regarding Ifat's family, your family.
Yeah.
So Ifat, is it Ifat is your only child?
Yeah, actually for now, Norifa is my only doctor, yeah, in family.
Okay. Okay, so how old are you right now?
28 years old, and my husband 26, younger than me.
Okay. So is your husband a close relative?
No.
Okay. Where does Ifat live? Where do you live, Puan?
Oh, she live with us lah. At Taman Sepekan Makmur, you know.
Okay. So what do you work as?
I'm as housewife, just housewife.
Your husband?
My husband work at the HRB High Court, DRB High Court.
What's his monthly income?
Total about 1,100.
So, oh, I see. Okay. I think that's everything that I would like to ask you. Thank you for your time, Puan. Thank you very
Okay.
much.
Okay. Thank you. So many of you, student.
Yes. Okay. So we've gone through with the role play. Now I'd like to give a brief summary on what I found from the history taking. So here the patient, Ifat Hafia, a 1 year 7 months old Malay girl, was presented to the emergency department at Hospital Pekan with complaint of high-grade fever for 5 days. It was preceded with cough, diarrhea, and vomiting. The child appeared lethargy and reduced oral intake due to the symptoms. No history of contact. So here's the HOPI I mentioned before. So based from the history taking, we could see that from the general system, there is fever, lethargy, and loss of appetite. And then also there is a productive cough also. And from the GI system, there is loose stool, vomiting, and redness at the perianal area. So I found that the other systems like the head and neck, cardiovascular, hematopoietic, and neurological findings are unremarkable. And also there is significant past medical and surgical history. So Ifat has a previous history of admission to the hospital Pekan at the age of 7 months for 3 days because of rapid breathing and wheezing. So to treat this, doctors have given her a nebulizer during her stay at the hospital. And because for the of the rapid breathing and wheezing, actually we're not sure what's kesihatan peramu for the nebulizer treatment. So birth history, there are some findings such as during antenatal findings, there is increase of blood pressure from the mother just before delivery. Intrapartum is uneventful, and yeah, postnatal thing. And for the nutritional history, the patient is exclusively breastfed up to 2 months and start formula milk for 8 times per day. And it started eating soft food which is weaning at the age of 6 months for 2 to 3 times per day. Yeah, that's for history taking. Next, for physical examination, from this patient, we found that there is, from general examination, there is mild injected tonsil, but with no central cyanosis. And other findings are negative, are normal for the general examinations, such as there is central trachea, and the hydration status seems to be good, which because of the capillary refill time, which is less than 2 seconds, and there is no cyanosis also, and no nasal flaring. For the vital signs, we found that the temperature indicates febrile, which is 38.7 degrees Celsius, and the patient appears tachycardic because of the high pulse rate, which is 125 beats per minute. pulse is regular rhythm and good volume. And for her age group, 36 breaths per minute is considered as normal. So here's the weight, which is also normal. So for the respiratory examination, however, there are no positive points. Everything seemed normal. However, percussion could not be done during of the respiratory system could not be done, as the patient seems to be irritable. Other systemic examinations are unremarkable also, and CNS nervous system examinations cannot also be done due to the patient being irritable. So that's for the history taking and physical examination. So let's proceed with the differential diagnosis. Juan.
Okay, Assalamualaikum warahmatullahi wabarakatuh.
Sorry, can you provide a summary? Like a
Oh, okay.
2-line or 3-line of summary?
Okay. So summary is that the patient comes with a fever 5 days, high grade fever, and proceeded with cough, diarrhea, and vomiting. So from the physical examination, mostly the examination is normal, but there is positive finding of tonsil was injected.
Okay, thank you.
It's Mohammed Rahim. So I'll touch on the differential diagnosis and also the provisional diagnosis. So based on what Api has presented just now, our provisional diagnosis is pneumonia due to the viral infection. So why we suggest or why we do up to this provisional diagnosis is next slide. Next slide. Okay. Why we do is suggest this pneumonia because based on history, the patient's mother had complained where there is high grade fever for 5 days, and the patient remained ill with high grade fever about 5 days, and she also complained of the child have difficulty to sleep at night and seems irritable. Other than that, she also complained of lethargy and loss of appetite. Okay, one point I would like to highlight here is in the assessment of severity of pneumonia in the children, according to the pediatric protocol, for the age of more than 2 months to 5 years, if the child is unable to drink, it might indicate very severe pneumonia. But the mother just complained that this child only loss of appetite. Okay, and also this patient also have chesty and productive cough that might caused by and also the cough is whitish in color, right, in nature, so it might suggest viral cause. And also enlarged tonsil might indicate infection. And also on the chest radiograph imaging, the result was patch consolidation in the patch over the right perihyla. Okay, now we proceed to the differential diagnosis. Okay, so we have 3 differential diagnoses, which are bronchial asthma, acute gastroenteritis, and also dengue fever. We go one by one. First of all, bronchial asthma. is one of differential diagnosis due to the similar symptoms such as history of coughing that especially worsen at night. And she also has history of hospitalization last year, 3 days in ward due to the rapid breathing and also wheezing. And at that time, the doctor give her nebulizer treatment. And I would like to point one important thing here is it is often difficult for us to make diagnosis of asthma in this age of group. Episodic wheezing and also cough are common in children with asthma, especially in those 0 to 2 years old. And other than that, she also has history of frequent nebulizer treatment about once a month. And the points against the bronchial asthma is that there is no episode of wheezing in the current admission, and also no family history of asthma, especially in this degree relative. And finally, the third difference.
Sorry. Can I ask you one question? Very simple questions. This differential diagnosis, is it yours or actually this is someone else differential diagnosis that you are presenting?
Our previous
this your so from the case right out, so this is the differential diagnosis of the person who wrote the case
this
right
is
out.
another candidate just presented to give the background, and then we are discussing him again, Dr. Alwi.
Okay. So this is yours. So based on the history, you come up with all these differential diagnoses, is it? I'm sorry,
yes.
I'm a bit clueless. So this is your differential diagnosis based on the history presented by your colleague.
Actually, I will take it from the case right up.
Okay, so you take these are the differential diagnosis that is presented in the case right out.
Yes.
Right.
Yes. Okay, may I continue? Shall I continue?
Maybe I think I just ask before we go further.
Yes.
So what is the reason? I mean, what makes you guys think this is a pneumonia? What is the main reason that you guys think this is pneumonia? Because I can't find any in the history or your presentation, anything that suggests pneumonia. None. And in fact, I think you present you justify the justification given for pneumonia is actually I don't think it's adequate. Okay, how you actually diagnose? How do you diagnose pneumonia?
Chest X-ray.
Yes.
Okay, chest X-ray. Besides that, do you need chest X-ray to diagnose pneumonia? Is it a must?
Not really. Sometimes.
Okay, you cannot say must lah, because for example, if you are in district or someone in rural or maybe in Africa ke tak ada, where there is no chest X-ray, then you cannot say it's a must. Okay? Case definition for pneumonia doesn't include chest X-ray actually. It's supported by chest X-ray. So what else? What else have to be there before you diagnose pneumonia?
Blood count.
Besides
blood
X-ray.
culture.
Okay, again, blood count, blood investigation is not a must lah for pneumonia.
The triad of clinical
Because
signs.
doesn't tell you whether this.
The triad.
Okay, what are the clinical signs?
Fever, cough, and rapid.
Triad of what?
Symptoms.
Fever.
Fever.
Where do you get this?
And this is from illustrated textbook of common presenting symptoms.
So that's a common presenting symptoms, right? So assuming this is right, so you've got the three clinical signs, which is rapid breathing, tachypneic, you've mentioned cough and also fever.
Yes.
Okay. Is there any, was the patient have all the symptoms and signs?
Yes, he got fever, cough.
Fever, cough, and is there any rapid breathing or tachypnea?
No.
No. Actually, based on study, based on observation study, the most specific, there's no actually 100% specificity, but the most specific symptoms for pneumonia is actually two, which is tachypnea and also fever. Okay. But in this child, there's no tachypnea, right?
Yes.
No tachypnea, there's no craps, or there's no additional sound from respiratory examination to suggest pneumonia, kan? Am I right?
Yes. Yes.
Okay.
Yes.
Except for there's X-ray shows perihilar haziness,
Consolidation. Yes.
consolidation. Okay. So what actually support? Why is pneumonia in the top of the list? Why can it be anything else? And what explain the AGE symptoms, the GI symptoms in this particular patient? Does it mean the patient got two pathology? You get what I mean, kan? You understand my
Yes.
question, kan?
Yes.
So what makes you actually think this is pneumonia? I'm sorry, but because from your presentation doesn't sound like pneumonia at all. I don't know, maybe Dr. Mossad can clarify further lah, but from your presentation, I don't think there's nothing to suggest pneumonia actually. But again, if this is pneumonia, then it will be an atypical pneumonia lah, because with extrapulmonary manifestation. But I think maybe Dr. Mossad can clarify. Okay. Or maybe you can just continue with your, continue with your differential.
This presentation now is speaking, Doctor, about the pneumonia as a general. Previously, he presented the case, okay, which are going to discuss the differential diagnosis. And my suggestion for my student that any diagnosis must go through clear steps. I mean, we'll start by history, which give us up to 70 or 75% of the truth, and then 20% related to the clinical examination, and the lowest, as Dr. Alwi speak, is about 5 or slightly more is the investigation. If you are a doctor of investigation, that's say you are used to ask all investigation for everything, it is not good. Even your clinical sense will not be. So you can put differential diagnosis, but you must say, what is my first differential diagnosis? What can be the differential diagnosis, okay? Working diagnosis, which is the top, and the other which you must put in your mind to rule out. So we can just finish your slides and we will comment at the end. Okay, Dr. Alwi?
Yes. I think that's sensible.
Continue your presentation.
And the last differential diagnosis we state here is the dengue fever. In dengue fever, there is some of the complaints that might suggest dengue fever, which are the high-grade fever, lethargy, and her mother also mentioned there was fogging activity around the neighborhood 3 weeks prior to the present symptoms. That might suggest the dengue fever, but There is also symptoms that did not rise in the patients that suggest it should be dengue fever, such as no rash and no bleeding tendency. That rules out the dengue fever. So that's all from me.
Next presentation, yeah, discussion, okay.
Okay, my name is Hanis and I will present about the discussion. Next. Based on the provisional diagnosis, I will explain more about pneumonia. Okay, pneumonia is an infection of the lower respiratory tract that involves the airways and parenchyma with consolidation of the alveolar space. And next. The etiology of pneumonia often not identified in 40 to 60% of the cases, and most of younger children are affected by virus, while older children are affected by bacteria. And the differences between viral and also bacteria are subtle and may be difficult to distinguish it clinically. Therefore, we have to do further lab tests in order to get the final diagnosis. Okay, next.
I think this one cannot be defined. It means by lab. I mean the blood culture and like that. But clinically, you will find another clue. Is it bacterial or viral, like full blood count, inflammatory markers? Okay, but it is even known that the blood culture and the other culture usually can be presented up to 40 to 60%. Okay. So I mean, which microbe sometimes you got it only by about half of the patients only. Okay.
Okay. Okay. Before that. Okay. Next. Okay. This is some of etiologic agents according to age group. Okay. As for newborn, they are usually infected with group B Streptococcus, E. coli, Klebsiella species, and Enterobacteriaceae. As for infant and young children, they are usually infected by respiratory virus, Chlamydia trachomatis, and Bordetella pertussis. As for preschool age, they are usually infected by Streptococcus pneumonia, Haemophilus influenza type B, and Staphylococcus aureus. For less common is group A Streptococcus, Moraxella catarrhalis, and Pseudomonas aeruginosa. As for school-age children, the etiological agents usually Mycoplasma pneumonia and Chlamydia pneumonia. Okay, next. Okay, for the clinical presentations, age is a determinant in the clinical manifestation of pneumonia. As for neonates, they usually present with fever and hypoxia only, with subtle or absent of physical examination findings. As for young infants, they usually have apnea and may be the first sign of pneumonia. As for older infant and children, they usually have fever, chills, tachypnea, cough, malaise, pleuritic chest pain, retractions, and oppression due to difficulty of breathing. Next. Okay, this is the clinical presentations for viral and also bacterial pneumonia. As for viral pneumonia, the patient will present with cough, wheezing, stridor, fever is less prominent. The patient will have mucosal congestion and upper airway inflammation. As for bacterial pneumonia, the patient will come with higher fever, chills, cough, dyspnea, and auscultatory findings of lung consolidation. Next. Okay, for this patient, come with high grade fever for 5 days. She also have productive cough with whitish sputum, which may indicate viral infection. The patient also appear ill, lethargy, and reduced oral intake due to loss of appetite. The patient also have sleep disturbance at night, and the physical examination reveals no abnormal findings on the patient except that she was tachycardia and febrile. The absence of abnormal finding may be due to the treatment that were given during the admission before. Okay, next. Okay. Next is investigation. Okay. In pneumonia, we can do chest radiography. It may confirm the diagnosis, but it is not reliable in order to differentiate between the virus and bacterial pneumonia. Next, we can do nasopharyngeal aspirates. It helps in order to identify the viral causes. Next, we also can do full blood count. Okay, as for bacterial infection, the patient will have increased white blood cell amount. As for viral infection, the patient will have leukopenia. We also can do blood culture. It is a non-invasive gold standard in order to determine the causative agent, but it have low sensitivity, which the positive result only in 10 to 30% of the cases only. Okay, next. As for the investigation for this patient, we do the full blood count. It reveals that this patient have leukopenia, which may indicate the viral causes. And on the chest radiograph, there's a presence of fatty opacity on right perihelum that's suggestive to pneumonia. And for C-reactive protein, it is slightly increased and it may suggest the viral causes of pneumonia. Okay, next. As for management, the therapy for pneumonia include the supportive and specific treatment, and the therapy depends on the degree of illness, complications, and the causative agent. Okay, we can give antibiotic, but it depends on the severity of pneumonia and causative agent. But majority of infection that is caused by virus does not require antibiotic. But if the pneumonia is severe, we can give second-line antibiotic like cephalosporin, which is when the patient have no sign of recovery and the patient remain ill with spiking temperature for 48 to 72 hours. Next. Okay, next we can give supportive treatment. First is fluid. Okay, this we give especially for children in severe respiratory distress, which is usually due to the withhold of oral intake. And next we can give oxygen. In function, this is function in order to reduce the mortality associated with a severe pneumonia. And then oxygen also is given to patients who are restless, tachypnea, with severe chest injury and cyanosis. The oxygen also function in order to maintain the oxygen saturation to be more than 95%. Okay, we also can give cough medication, but it is not recommended as it can cause the suppression of cough and may interfere with airway clearance. Okay, last is we can do temperature control as it can reduce the discomfort from the symptoms. Okay, next.
So yeah, you cannot so cough medication is not recommended. Yes, only if you have some mucolytic, if there is viscid secretion can be used, but cough medication it is not recommended. Okay.
Okay, this is some antibiotic that can be given according to the pathogen infect the patient. The first is Streptococcus pneumonia. We can give penicillin and cephalosporin. For Haemophilus influenza type B, we can give ampicillin or chloramphenicol or cephalosporin. As for Staphylococcus aureus, we can give penicillin and cephalosporin. If the patient is infected with Bordetella pertussis, Mycoplasma pneumonia, or Chlamydia pneumonia, we can give macrolides such as erythromycin or azithromycin. Okay, next. Okay, as for this patient, she received syrup paracetamol in order to relieve her fever, and she also get antibiotic treatment, which is due to the patient unrelieved fever. And this is because the second line antibiotic, like cephalosporin, is given when there is no sign of recovery and the patient remains ill with spiking temperature for 48 to 72 hours. As our patient is have high grade fever for 5 days. Okay, that's all. Okay, Bismillah. Can I please share the screen? Because I want to use the pointer. I'll just.
Okay, sure. I'll stop presenting.
Right. So my name is Amina Abdulrahman, and I'll be wrapping up this discussion on with a few questions on pneumonia and also a little discussion along the way. So I'd really appreciate if you all would try to answer. Okay. Right. Okay. So this is question number one. A 2-year-old boy was diagnosed with pneumonia. So what are some of the possible organisms that could have caused this disease? Can anyone answer?
Respiratory syncytial virus.
Right, good. Okay, what else?
Influenza virus.
Yeah, okay. What about bacterial causes?
Streptococcus pneumonia.
Yes. All right. So, yes. So remember that the pathogens will differ depending on the age. So according to Nelson's Essentials, in children aged 3 months to 5 years old, these are the most common pathogens in rough order of frequency. Right. So next question. What are the most common presenting symptoms in pneumonia?
Fever, tachypnea, cough.
Okay, good. Yeah. So right. So fever, rapid breathing, and sometimes cough are some of the most common presenting symptoms. But like Dr. Alwi said, that fever and rapid breathing are the two most important symptoms that you will look for. In this patient too, this 2-year-old boy, he presented with just high-grade fever and rapid breathing. So yeah, sometimes cough may not be present. Okay, what can we do to prevent pneumonia?
Vaccination.
Okay, yeah, good. So aside from general preventive strategies like washing hands and avoiding infectious contacts, like this can be hard for parents who send their kids to daycare and so on. So apart from these strategies, vaccination is the main mode of prevention. So you can give the annual influenza vaccine. It is recommended for children over 8 months of age. And of course, you have the Hep B and the pneumococcal vaccine, which is already taken routinely. And also in some high-risk patients like preterm babies, you can use palivizumab to prevent respiratory syncytial virus infections. Okay. Oh, so this is just a table showing the common symptoms by age group. Okay. And this is a very brief.
I will finish this lesson and go. Can you see, you leave this light?
Yeah. So
Can
this is a
you
brief, perhaps oversimplified summary of the differences in the features of some common respiratory problems. So we can have a look at them later. Okay, so let's move on to question 2. Can you name the clinical signs which are shown in this picture? What about this? Let's begin with this picture. What can you see?
Nasal flaring.
Okay, yeah, good. Okay, what about this? It's pretty obvious. What does this show?
Intercostal recession.
Okay, good. And this one?
Subcostal recession.
Okay, and this?
Bluish,
Cyanosis.
cyanosis, bluish, yeah.
Yeah, okay. So these are some of the physical examination findings that you can sometimes see in a child with pneumonia. And you need to be able to recognize the symptoms because they indicate that the child is in respiratory distress. So can you tell me some other signs of respiratory distress in children? What other signs of respiratory distress apart from these?
Tachypnea, tachypnea.
All right, yeah.
What else? Or symptoms?
Wheezing.
Wheezing, perhaps, okay.
Thalassemia,
Sorry, tachypnea, yeah, okay.
Grunting.
Grunting, yeah, especially in younger children, right? Anything else?
Use of accessory muscles.
Yeah, which is indicated by these recessions, just wall recession. Okay, so I'll teach just for you to understand more. Okay, so apart from right, so apart from those shown above, these are some of the signs of respiratory distress. So tachypnea would be there. You'd expect it to be there in most cases. I mean, it has to be there in pneumonia, but depending on the severity and also whether it's associated with these other signs, then it would indicate respiratory distress. Okay, so the severity of these symptoms and the signs would also correlate with the severity of the pneumonia. So according to pediatrics protocols, these are the criteria for classifying into severe or very severe pneumonia in children less than 2 months, and into mild, severe, and very severe pneumonia in children from 2 months to 5 years old. Okay, so if these signs of if these symptoms and signs are present, it's a good indicator that it means that the pneumonia is severe, so the patient would need hospitalization. So obviously this doesn't happen in all of the cases, and many of the cases in pneumonia cases are mild and can be managed at home. So you need to be able to recognize the signs which shows that it's severe and needs to admit to the hospital. So for example, also according to pediatric protocols, these indicators would signify that they need admission. Children aged 3 months and below, so any child 3 months or below, whatever the severity is, has to be admitted. If you notice from here also, from before, there was no mild pneumonia in less than 2 months. It's straight away severe. So yeah. Fever more than 38.5 degrees or refusal to feed and vomiting, fast tachypnea with or without cyanosis, any associated systemic manifestations, failure of previous antibiotic therapy, or if the patient has recurrent pneumonia or any severe underlying disorder, they also have to be hospitalized. All right, let's move on to the final question. So an 8-year-old presents with 1 week of fever and cough. Chest X-ray was done. Can you name a finding from this? Anything that you can see?
Increased perihilar marking.
Okay. What else? Maybe along here. Can you okay.
There is a opacity in the left lower zone, which
okay. So, in this picture, there is an opacity here in the left lower zone as mentioned, and this indicates an area of consolidation. So if you can see, it's this is in a normal X-ray how the heart border would be clear. In this case, the heart border is obscured, as is usually seen in lingular consolidation. There's obvious loss of the left heart border. So this is a nice picture which I found in illustrated textbook of pediatrics. It shows how the consolidation would look in different lobes. So for example, here in the right upper lobe, it's over here, and it also causes a loss of volume in this lobe, and yeah, so on. So various lobes. It's like, I don't know, it's a really nice picture. Okay, moving on. So apart from, right, so in pneumonia, there is a spectrum of different radiologic appearances or radiologic findings. So apart from the lobar pattern, where the entire lobe is consolidated, there are also other types. For example, like in bronchopneumonia, where it's known as like the patchy type, not the lobar type. So here there are lobules that are affected, and the instead of like here when the whole lobe was consolidated, it's just there are just scattered patches of opacity. because of just depending on the affected bronchioles and the alveoli next to it. So yeah, so in bronchopneumonia, the severity of the findings would differ with the severity of the disease. So yeah, all right. Okay, yes, so that's it for the questions. Any? Okay.
So, Dr. Alawi, can you, hello?
Yes.
Can you now discuss the doctor? All these are just helping him. The doctor, the first one sent to you, you can discuss the case as if he is an exam, please, even for a few minutes.
You mean the case?
Yeah, the case,
mean to
his
wrap-
case.
right.
His case now, he will, after we give him all this knowledge, we are now going to discuss him again.
Okay. Okay. First of all, as I mentioned earlier, I think we have to clear how to diagnose pneumonia. Pneumonia is very common, so you need to know how to diagnose pneumonia. And you have to open your mind. There is a lot of differential diagnosis. For in this case, I don't actually agree with the diagnosis of pneumonia as the primary diagnosis, because it doesn't fulfill any except for the fever. And besides, the only positive findings from the physical examination you've mentioned is the tonsil, enlarged tonsils, and then the cough. These are all actually upper respiratory tract rather than lower respiratory tract. So actually the your main diagnosis should be upper respiratory tract rather than lower. But pneumonia still can be in one of the differential, but you need a very strong suspicious and supported by evidence. That's one thing. And then I think your colleague asked about primary prevention for pneumonia. Vaccination definitely is one of the prevention. But again, palivizumab is not the vaccine. Okay? Palivizumab is not the vaccine. It's a passive. It's a passive artificial immunity. So when we talk about vaccine, we are talking about passive natural immunity. It's not a passive artificial. So palivizumab is not the vaccine. And then primary prevention is actually the main measures to prevent pneumonia is avoid overcrowding. So we know the risk factor for pneumonia is overcrowding. For example, if the child was sent to school or to preschool or kindergarten or nurseries with overcrowding, this is the risk of pneumonia. And then hand hygiene is very important. So these are the measures to prevent pneumonia. Avoid smoking or smoking environment. Also measures to actually prevent pneumonia lah. What else? I think that's all. You asked for my comment, right? Actually, I don't quite understand. I think so. That's my comment lah. And to me, if you got any positive findings, then the positive finding should explain your diagnosis. So none of your diagnosis actually, you can actually put tonsillopharyngitis as your diagnosis because you got tonsillar enlargement, kan? Then it should be in your differential lah, because your differential should explain your findings, kan? And then and ideally, if you got patient with multiple signs and symptoms, you have to try to combine those and to be able to explain in one pathology rather than multiple pathology. It's very unlikely for a child or for anyone to get like multiple pathology in one go. Usually it can be described by one pathology that have multiple presentation. So in this case, you have to be able to justify or to explain what caused the GI symptoms in this child. Can you can say I think the most probable diagnosis to my mind is actually upper respiratory tract infection, for example, tonsillopharyngitis with parenteral diarrhea. that's the most sensible diagnosis rather than pneumonia than lower respiratory tract infection. But again, you can put pneumonia because there's no definite sign and symptom to diagnose pneumonia. But again, it should be at the bottom of the list. That's my comment lah. Comment, right? Okay, that's all.
Okay, so now, Ikwan, are you the one the doctor?
Afi.
Me, doctor.
Okay, just give us the summary now. Just a summary in 2 or 3 sentences.
So, the patient named Ifat Hafia, a 1-year-old, 7 months, Malay girl, presented at the emergency department with high-grade fever for 5 days. Has preceded symptoms of cough, diarrhea, and vomiting. So, in physical examination, there is only positive findings of tonsil was injected. Other physical examinations are normal.
So tell me, please, while auscultating the chest, what are you commenting about?
So during auscultation, it's found that there is vesicular breath sounds. And also during respiratory examination also, percussion cannot be done as the child was irritable.
No, I am auscultation. If you are auscultating the chest, you comment now it is vesicular sign, vesicular
breath.
Not bronchial one. Okay. So this is against pneumonia. The other thing is the air entry, decreased or increased or normal.
Air entry equal in this patient.
No, it may be equal and low. Equal and high. Equal is different than is it good or bad. We may be both of us equal, but we are very excellent. Maybe equal, but not so. So it is equal, good bilateral, equal.
Yes.
Wala bad, wala decrease air entry bilateral.
Equal air entry bilaterally.
Okay, and no added sounds.
No added sounds in this patient.
Okay. As Dr. Alwi told you, usually bacteria is restricted to one organ. It will cause like pneumonia more. It will cause abscess like that. Viral, like fleas. It will affect the gut. It will affect the tonsil. It will affect the chest, like that. Many areas. Okay, but at this situation, sometimes the pneumonia can cause vomiting. Okay, but we don't have more symptoms related to the issue of bronchopneumonia unless the patient are partially treated. I mean, if the patient was started during these 5 days by antibiotics, which may sometimes mask the infection, but need to be completed, maybe this one. Okay, and also as Dr. Alwi said, some atypical one may be discrepancy between the X-ray and the clinical signs. But I think this may not be the case at that time because the atypical, it will be a bit late, preschool and school like that, okay? So this is the art of differential diagnosis now. Okay, the most important lesson for us is the art of differential diagnosis. It will be one symptom only, like fever, okay, like diarrhea, like cough. And our mind must be processed by a lot of differential diagnosis, not to miss it. Because you will see 10 patients in one day, everyone is different scenario, is different diagnosis, is different protocol, is different intervention and investigation. That's why we need you to be fully oriented, okay, about all that. You need to ask Dr. Alawi or me any questions? Amina?
No, it's not.
No questions? Okay. So if you don't have any questions, let us today come to our end of session. We got two important lessons that our history are very important. We must be able to be directive history taking to come to the conclusion. Okay, we must be able to define for every case what is the diagnosis and what is the possible differential diagnosis. Okay, and even for the diagnosis, as in the first case, we can say just gastroenteritis, but he said after that it is acute gastroenteritis with mild or moderate dehydration, with most probably infective with viral. So sometimes our diagnosis must be completed. Okay. At the same point, these two cases which you presented today is the most common cases in pediatric and childhood. And they are the most common cases also of morbidity and mortality. Don't underestimate it. That's why you will come with us and you will see what about cough, you will find asthma, all your differential diagnosis from simple to complicated, from upper respiratory to lower respiratory. All these are very important. Hoping, inshallah, to have escalating schedule. Okay. Thank you for this good start, and hoping to see you, inshallah, either online or in the hospital. Thank you. Assalamu alaikum. Thank you, Dr. Alwi. Assalamu alaikum wa rahmatullah.
Waalaikumsalam. Thank you, Doctor.
Thank you, Dr. Mossad and Dr. Alwi.
Thank you, Doctor.
Thank you all. Okay.